All right, good evening, folks, and welcome to the Health Equity Grand Rounds Echo. This is the third of our six-part series exploring racism in medicine, health equity, and COVID-19 in Alaska. This echo is jointly provided by the Alaska Black Caucus and UAA Center for Human Development, Project ECHO, with support from grant funds awarded by the Municipality of Anchorage, Anchorage Health Department. My name is Erin, my pronouns are they, them, and I'm an ECHO coordinator with the Center for Human Development's ECHO project. Long title. All right, so as typical, we'd like to get started with an introduction from Deanne Woodard as a representative of the ABC team, who will share a bit about the vision that's driving this initiative and the purpose of our ECHO. Deanne.
Thank you so much, Erin. First, I'd like to just say thank you to everyone for joining us this evening and share a little bit about the Alaska Black Caucus. This is the premier nonpartisan 501c3 nonprofit organization working to assert the constitutional rights of African Americans in Alaska, recognizing that racism is a public health crisis, which was only amplified by the COVID-19 pandemic. The ABC partnered with UAA's Project ECHO to deliver a Grand Round style health equity series. Grand Rounds are historically a part of medical education in which clinical reasoning skills are enhanced under the guidance of expert clinicians. The ABC wants to use this framework to create a forum for Black community members and experts in various fields to connect with healthcare providers, leaders, and trainees in order to address racism in medicine, disparities in COVID-19, and work towards our shared goal of health equity in Alaska. This project is one of many strategies that ABC is using to decrease racism-based health inequities in our state. So thank you for joining us for this presentation. We appreciate your participation and encourage you to engage fully with this process, as well as with all of our work around health equity. So again, thank you for joining us.
Thank you so much, Deanne. And for more about all of the great things that the Alaska Black Caucus is doing, we can go ahead and put their website with their programmatic offerings in the chat for folks to utilize. Check it out. There are really great community conversation sessions that run regularly. All right, so again, thank you to folks joining us. And whether or not you've joined in on ECHOs before, it's important to know that engagement with the group is integral to the all teach, all learn philosophy that underpins our program. We encourage everyone to ask questions and make comments during the session by utilizing the chat box, or when appropriate, by unmuting yourself and sharing directly with the group. You're also welcome to private chat the session host, myself, or any member of our hub team if you'd like your questions shared anonymously. We are also happy to offer CME, AMA, PRA Category I, and Nursing, ANCC credits for our series. And in order to claim these credits, you must attend our live session and complete an evaluation, which will be linked in the chat at the end of our session. Once you've completed that assessment, you'll be redirected to a JOT form where you can fill out and download your certificate of completion. I'm pleased to announce that this evening session is on trauma-informed care and the impact of collective race-based trauma on individual health and pathways to collective healing, and features a didactic and case presentation from Dr. Tabitha Grier-Reed, a licensed psychologist and associate dean for graduate education and faculty development in the College of Education and Human Development at the University of Minnesota. Following that, those didactic and case presentations, we'll go ahead and have a Q&A session, which will be facilitated by LaShonda, our member of our hub team. And a few Zoom reminders then before we get started here. So if your internet connection does not support audio, you can find a phone number to call in the chat box along with the meeting ID. Closed captions are automatically generated and available by pressing the CC button on your Zoom screen. Please take a moment, if you're able, to turn your camera on, which allows us to get to know each other just a little bit better. The camera icon is on the lower left of your screen. And again, we do ask that you keep your microphone muted during our presentations and when you're not speaking. You can mute and unmute yourself by clicking the microphone icon on the lower left of the screen, or by pressing *6 if you're calling in via phone. And to help further build connections and foster participation throughout our ECHO, we like to start each session with introductions. We'll go ahead and start with our hub team. And hub team, as I call on you, please introduce yourselves with your name and pronouns, your role in organization, and what drives your passion for health equity. Participants, feel free to share the same of yourselves in the chat box, and also let us know what you hope to receive from this ECHO, this series at large and this session in particular. We welcome the opportunity again to get to know you just a little bit better. All right, let's go ahead and have introductions starting with LaShonda.
Okay, great. Everyone, I'm LaShonda McGowan. My pronouns are she and her. I'm here as a hub member invited by the Alaska Black Caucus. I'm a social worker and I work as a clinician at Alaska Behavioral Health. My hopes in participating in all of the ECHO sessions are to grow in knowledge and also share my own lived experiences and wisdom with others. And I really want to be a part of the change that's happening here in the state. And so, yeah, that's pretty much it.
Thank you so much, LaShonda. Panna, if you would.
Good evening. Welcome all participants. My name is Panna Lynch-Jerusi. My pronouns are she, her. I am a school nurse with the Anchorage School District, serving my 21st year at Robert Service High School. My passion and my doctoral degree focus brought me to be part of Alaska Black Caucus and the Health Equity Grand Rounds ECHO in a desire to operationalize health equity for marginalized populations in Anchorage. Thank you again for joining us in our Grand Rounds discussion this evening.
Thanks, Panna. And Maddie.
Hi, good evening, everybody. My name is Maddie Mandap. My pronouns are she, her. I'm an integrated pharmacist working at South Central Foundation on Denina land here in Anchorage. I'm here because I'm passionate about allyship with others in combating health disparities and recognizing our intersectional identities. And I hope to maybe share my lived experience as a Filipino-American queer woman. Happy to be here. Thank you.
Thanks so much, Maddie. Allison.
Hi, everyone. My name is Allison Horgan. I use she, they pronouns. I'm a fourth-year medical student at the University of Washington in the Alaska WWAMI program, and I'm currently serving as the co-chair of the ABC Health Committee, and I'm so excited for our session today. This work is so vitally important and necessary, and I'm thrilled to be a part of the group that we've gathered, so thank you all.
Thanks, Allison. Tracy.
Hi, good evening, everyone. My name is Tracy Weiss. I'm the clinical director at Identity Health Clinic, and I use she, her pronouns. Identity Health Clinic is the only nonprofit health clinic in the state of Alaska that serves the needs of the LGBTQ2IA+ community. So I'm here because my career has always centered around healthcare for vulnerable populations. And I think in recent years, as healthcare providers, we're all being called to specifically look at that as it pertains to race and be a part of these conversations and really to listen and learn and ensure that we're a part of the shift that needs to happen and definitely ensure that we are not part of perpetuating things that have been happening. So happy to be here. Thank you so much.
Thanks, Tracy. And Obi.
Hey, good evening, everyone. My name is Obina Alu. I'm currently a pharmacist transitioning towards a legal career. And pronouns he, him, and currently excited to be part of the work that the Alaska Black Caucus is doing in this collaboration with UAA. This is definitely something that has meaningful impacts as far as healthcare outcomes as it relates to race. And anything that we can do to bridge that gap and further address this issue is something that I'm definitely proud to be a part of.
And Jay.
Good evening, everyone. My name is Jay. I'm the executive assistant for the Alaska Black Caucus. There's just a lot of great information, so I'm just happy to, be a part of it. Thank you.
All right, thank you so much for those introductions, Hub team. All right, a few final reminders before we get started. The opinions of our hub team and presenters are their own and do not necessarily represent those of the Alaska Black Caucus, UAA, the Municipality of Anchorage, Anchorage Health Department, or any ECHO sponsors. And again, for those who might just be joining, we encourage you to introduce yourself in the chat box by sharing your name, role, organization, and what you hope to receive from this ECHO series. All right. Additionally, Project ECHO is not HIPAA compliant. Therefore, we ask that no protected health information be shared or displayed at any time. And finally, I want to acknowledge that the subjects we're discussing carry weight. As we will explore during this series, racism and its impacts are not abstractions. They exist materially, bodily, emotionally, and spiritually. I invite those joining in on today's discussion to do so with that in consideration, to listen, to keep questions and comments on topic, to be considerate, and to use language that is respectful, especially when in response to those with lived experience and expertise. So thank you to everyone for following those guidelines. And with that, folks, I'm so pleased to turn our session over to Dr. Tabitha Grier-Reed for her presentation today. And Dr. Grier-Reed, feel free as you desire to also introduce yourself in ways that feel good to you to the rest of our group here.
Hello, thank you for inviting me here this evening. I appreciate all of the community that I see and that I feel, even in the Zoom room with all the boxes, the two-dimensional, not as good as the three-dimensional, but it still feels pretty good in this space. I hail from Minnesota, so it is about 9 o'clock at night where I am, but I am rallying. This is an important topic and an important discussion, and I'm so honored to be invited. With that, I am going to share my screen and move right into my presentation. My pronouns are she, her, and as Erin mentioned, I am a licensed counseling psychologist, also Associate Dean in the College of Education and Human Development at the University of Minnesota. And because I do not like watching my face as I present, it is very distracting, I'm gonna mute my face and actually go into full screen here so that hopefully my slides will be easier to see.
It looks great.
Thank you. So let me make sure my keys aren't sticking. Here we go. I want to open with some thoughts from bell hooks, one of our now ancestors, as we begin this conversation. And that is the idea that no level of individual self-actualization alone can sustain the marginalized and oppressed. We must be linked to collective struggle, to communities of resistance that move us out and into the world. My hope for you today is that as we move into this space, you'll come away with the ability to do three things, and that is recognize anti-Blackness, or perhaps gain more literacy in your ability to recognize anti-Blackness, identify racialized labor and examples of that labor, perhaps in your everyday life or in the lives of others, as well as examples of racial battle fatigue. And then finally, be able to develop or at least describe responses to racial trauma, racialized labor, and racial battle fatigue that can facilitate or move us into cultural health. So let's start with the first three: anti-Blackness, racialized labor, and racial battle fatigue. Anti-Blackness has a long and storied history in US society and US higher education, where oppressive policies and structural violence, blatant disregard for Black existence really stem from the white racial frame. And the white racial frame is a set of cultural narratives and symbols that are based in white supremacy and that shape perceptions, ideologies, and even emotions in US society. The white racial frame provides the foundation for what we think of as structural racism, and is really thought to shape individual experiences where anti-Blackness encapsulates the continuous dehumanization and marginalization of Black people in the US. Now, in a study that I published with a couple of graduate students in 2018 entitled Encountering the White Racial Frame, one of the things that stood out to me was just how little room there seemed to be for students' authentic Black selves in their classes at their predominantly white institution, where white ascendancy, or just whiteness as the natural order of things, really predominated. And racialized narratives about Black people included negative stereotypes like African Americans not even valuing education, or perceptions that the Black students who got in were really just taking the space of better qualified, more deserving white students. Anti-Blackness as a subframe of the white racial frame really, in my experience and in my research, pulled from lived experiences of racial trauma, racial rejection, racial microaggressions, and systemic racism. And I'll just talk a bit more about each of these as I'm sort of morphing some of my studies together. But when people experienced racial trauma, or when these experiences were conveyed or came up in AFAM, they tended to result from experiencing or witnessing racism, race-based stressors, and/or discrimination, where racial trauma is really similar to post-traumatic stress disorder in its symptomology, but it differs because of just the continued exposure and re-exposure of race-based stressors that impact both the individual and the community. So events of danger, this study spanned discussions that happened for over a decade. So they included news events like the Jamar Clark verdict, which happened probably 10 years ago in Minneapolis, as well as things like the Muslim ban, police interactions and harassments. And I can't help but think today about the news, what's been all over the news about the Black man killed in Michigan. But racial trauma involved those events of danger as well as threats of danger that didn't even have to be something that somebody personally witnessed or experienced, but they could be vicarious just through stories, through news events, through things that happened to other people. And the 2016 election was actually a very traumatic event where there was heightened sense of threat due to the election and the uprise in racist and Islamophobic events. Racial trauma also involved shame and humiliation, being called racial epithets, being criminalized, over-sexualized, and just made to feel stupid, degraded, dirty, and marginalized. Racial rejection was really about capturing a sense of not belonging or feeling excluded and unwelcomed in white spaces. And it was sort of like a feeling of being institutionally unwelcomed. So Black students, their histories, their experiences, their identities were not really well supported or well represented on campus or in their classes, and also didn't really seem to be highly valued in US society. And I was at a recent conference with Isabel Wilkerson discussing her book Caste, which I recently started reading. And I mean, I think that sums it up. Racial microaggressions have gained a lot of attention in the literature. And when students talked about microaggressions, this really seemed to fall into the category of cultural insensitivity, where students were in situations in which they felt silenced or invisible, validated, stereotyped, condescended, or just treated coldly, including just petty insults by instructors or others. And then finally, systemic racism, I often think of as just the good old-fashioned racism, where these experiences and perceptions were about just the larger institutional and societal disenfranchisement, with respect to economic and educational opportunity. You can think caste, which in Isabel Wilkerson's analysis, Black people are really at the bottom of the caste, akin to what used to be called the untouchables. And students pushed back against the white racial frame in general, and the subframe of anti-Blackness in particular, resisting or countering the white racial frame by working to educate others, to speak out, or push themselves to achieve, to prove that they belonged, that burden of proof that people like Terrell Strayhorn had talked about. In fact, encountering the white racial frame really involved considerable cognitive and emotional labor. For example, this notion of how do I stand up for myself without becoming or looking like a stereotype? It was a source of puzzlement and frustration and a lot of deliberation for students as they experience the kind of damned if you do, damned if you don't dilemma. And I've since come to describe this work and to think of this work as racialized labor, where you can think of racialized labor as the effort expended to navigate hostile environments that are steeped in a white racial frame. We're navigating a collective Black identity and one's individual identity in the face of stereotypes, and whiteness in white spaces can include the work of physical avoidance, withdrawal, escapism, dissociation, assimilation, code switching, explaining, resisting, either verbally or non-verbally or physically fighting back, and quite frankly, just making adjustments that presumably white people don't have to make. So as I started to dissect this idea of racialized labor, I identified 6 categories that I don't really feel like are perfect, but they were a start. And self-monitoring really involved the self-policing, that is the work of judging oneself against the politics of acceptability or white standards to prove that Black people are not indeed animalistic, oversexed, unintelligent, lazy, etc., but are dignified, polite, good, worthy, proper, human. And in the old days, things like a credit to the race, right? And the interesting thing about this kind of self-monitoring and self-policing is that it could sometimes involve policing other Black people. Respectability politics was at play here, and even at play in some of the adjustments that people made in terms of regulating their behavior with respect to white standards. And so code switching, for instance, was something that students talked about. Then they felt like they needed to sometimes develop a new language just for conversing with the dominant culture, pretending to be interested in things because these were the things they were supposed to be interested in, and usually based on white standards. So depending on the context or the environment, students shared stories of having to frequently code switch or change their language. And here, the active adoption of standards rooted in whiteness as a regulatory instruments of one's behavior and emotions was in play. And yet at the same time, questioning was a big part of this, where students questioned the need to code switch and whether it was indeed a healthy way to navigate whiteness while trying to live authentically in one's own Black skin. And this kind of questioning also involved critiquing whiteness and the white racial frame. I remember my one graduate student who was helping me analyze some of this qualitative data was taken aback by how literate students were, how they had all these terms for everything, like white fragility. And this was a few years ago. That's become much more in fashion now. I think Robin's book blew up since when George Floyd happened. But the students had all of this kind of literacy and developing literacy around questioning and critiquing, not just themselves, but also the white racial frame. And the labor of questioning involved meaning making of racialized events, in particular, like those microaggressions, right? The subtle covert racism that was often hard to name, hard to identify, but was deeply felt. And that was sort of death from 1,000 paper cuts kind of experiences. And in fact, finding places to affirm their racial and cultural identities and finding those spaces on campus, it was work. And I sometimes call it a labor of love, but it was still work. And in environments where the white racial frame rooted in anti-Blackness is the invisible default, it remains work. I recently reviewed an article that was about Black cultural centers and the roles they play from a space, place kind of framework. And it was really interesting because some of it was really just about like having these physical marcations and physical commitments to space that changed people's sense of belonging in the environment, that were affirming. And the fight to hang on to one's racial and cultural identity and affirm Blackness rather than give in to anti-Blackness, it really often led to racialized equity labor or being the change. And right as I was publishing this paper on racialized labor in 2020, Lerma, I think Hamilton and Nielsen, but Lerma et al. Published a paper called Racialized Equity Labor, which was really about all the work that Black students are, and I think maybe just students in color were doing at the time, students of color were doing at the time to make their institutions more accountable and more just. So the protests, the marches, the creating programs, the recommendations, a lot of unpaid and uncompensated labor to create more welcoming environments on their campuses. And they called it racialized equity labor. So sometimes students just had to work at self-protection. And that is this last category here that involved just avoidance, avoiding certain places, certain spaces, certain people, and certain topics. And this last category of racialized labor, to me, seemed directly connected to racial battle fatigue. Racial battle fatigue can be thought of as the felt reactions and emotions that are connected to racism, those emotional consequences of racism and navigating a white racial frame. And in addition to the emotions listed on the slide, these might also include things like hypervigilance, sadness, hopelessness, acceptance of racist attributions. And a racial battle fatigue really seemed to be one of the tolls of all the racialized labor that Black students experienced. So just like racialized labor involved navigating the white racial frame and often led to racial battle fatigue, this included just the cumulative racial trauma and microaggressions that were found in that anti-Blackness and that could affect both mental and physical health, often exacerbating ongoing issues such as depression and anxiety. And there is now a growing body of literature examining how people of color in the United States cope with race-related stress and how coping can either mitigate or exacerbate continued experiences of distress. For example, you think about that last category of avoidance. Some researchers have found that passive coping, such as not discussing an incident or accepting it as fate, can exacerbate experiences of racial trauma, negatively affecting one's ability to cope. Conversely, when you think about the racialized equity labor being the change, researchers have found that more direct problem-focused approaches can mitigate the negative impact of racially traumatic experiences. In fact, Forsyth and Carter found that the most effective coping strategies were those in which Black people asserted their rights and actively engaged the situation. Likewise, Polanco-Roman et al. Found that engaging with and discussing experiences with others reduced negative symptomology, along with relying on spiritual practices and self-soothing behaviors, in response to race-based stress. In short, I say this to say that it is possible to grow in the face of trauma. And Tedeschi and Calhoun identified different ways trauma might spark growth through their post-traumatic growth inventory, which focused on these 5 areas that you see here, where seeing new possibilities was measured by items like, I established a new path for my life. And this makes me think of activism, for instance. Many people got activated and have gotten activated in the last several years as a positive or growth response to the racial trauma. Relating to others, I put more effort into my relationships with others. I deepen my connections. Tapping into to personal strengths. You know, I discovered as a result of this that I'm stronger than I thought I was. Or spiritual change, right? I have a stronger religious faith. This is interesting. I'm from Alabama. So the Deep South, sometimes called the Bible Belt, but I also think about how the Black church was so foundational to the civil rights movement. And it's very interesting that spirituality and spiritual change and faith, all of this tends to come up over and over again in the literature as positive responses in terms of coping and growth responses in the face of trauma, and racial trauma in particular. And then finally, developing an appreciation for life with items such as I change my priorities about what's important in life, or I have a greater appreciation for the value of my own life. Now, some research suggests that post-traumatic growth may actually be even more pronounced in oppressed or racially diverse populations. And Black students, I found in my own research, who are more likely to be flourishing, are also more likely to report post-traumatic growth in the face of racial trauma. Where flourishing is defined as having meaning in life, having social connections, and a positive outlook on life. And flourishing is positively linked to health, nutrition, strong spiritual practices and beliefs, as well as forgiveness behaviors. The concept of flourishing encompasses 3 areas: positive emotional experiences, positive lived experiences, and positive psychological experiences. This does sort of come out of that positive psychology movement. And students who are characterized as flourishing report having more academic success, less antisocial behavior, and less substance use. And interestingly, they report less depression and anxiety, which is important given that racial trauma can exacerbate depression and anxiety. Now, there's little research examining the concept of flourishing for Black college students or Black people in general, but Mushanga and Hindenburger have found unique protective factors that may increase flourishing in the population of Black college students. And these unique factors are spirituality, social support, self-esteem, and racial identity. So that is feeling like one's racial identity is supported and respected in their environments. Now, to me, these unique factors point to the potential racialized aspects of flourishing that may be important for Black college students, but that can also be fostered in the environment, as research has shown that supportive college environments may contribute to flourishing among college students. So one of the implications, I think, is that colleges and universities and other institutions really may consider creating spaces where Black students, Black people can process racially traumatic experiences and just the Black experience, quite frankly, with each other in growth-oriented ways, where namely opportunities to connect with others, to see new possibilities, to identify strengths, to tap into spirituality, and to appreciate life are underscored. Okay. So now I'll move into this last part. I think I talked a lot faster than I did in my practice sessions, but
no worries. Actually, Dr. Grier-Reed, if it's possible,
for a second?
Yeah, if it's possible, we had a couple comments, and it'd be great.
There's like 29 things in the chat. Somebody's monitoring.
Yes, definitely. LaShonda will go ahead and facilitate, and we'll give our participants a chance to ask questions about your
Sure.
presentation.
Perfect.
Definitely. So first of all, thank you, Dr. Grier-Reed, for this presentation. I can totally identify with everything you're saying, and so I appreciate it. We're going to open up the floor for questions, and you can unmute your mics, or you can type your questions in the chat box. And then before you speak, please just reintroduce yourself. But before we go to the questions, there were some comments in the chat, and I took pictures of them to make it easier for myself. And so one of the comments was, I think it's Miss McDermott. She said, I'm a part of a course of childbirth education, and the stories of just accepting what they say and going along with it so the team doesn't call child family services. So that's an experience that she brought up, and someone else replied to her and just said, basically that it's really pertinent, and that it probably occurs across various pediatric care environments as well. So I don't know if you want to speak to that, Miss. I don't know how to say your first name.
My name is Sui Ghana.
Yeah.
Yeah. So I'm part of a national. Oh, excuse me. My dog picked up a squeaky toy. I'm part of a national childbirth education course, and compared to Alaska, a lot of childbirth educators and birth workers and midwives and such have shared that they have realized their clients will go along with like medicalization of birth just because the provider is saying you need to do this for your safety, your baby, and they fear, just basically because like they fear that they're going to get child and family services called on them, they agree to whatever is pushed on them without somebody else to advocate for them.
Yeah, I mean well, when I think about Black women and childbirth, and probably in your class, they talked about the disparities in terms of the rates of infant mortality. Like I can't imagine that hasn't been covered. For instance, just the level of, when we begin to think about the caste, right? Like how we have those levels of disparities in one of the richest nations in the world, and how Black women's pain and lived experiences, quite frankly, are either heard or dismissed. And so I have a student, I'm on a dissertation committee, and a student was writing their proposal, and this student is a fascinating student, and this proposal went many places. One of the places I didn't expect it to go was in the field of obstetrics and gynecology, which was sort of founded on the backs and genitalia of Black women who weren't even considered women. They were just considered, they were enslaved people and just considered, forced subjects that could be experimented upon without any regard for their humanity. And so I feel like there are these sort of deep issues around medicalization and medical racism that the institutions have to contend with, and for which we probably are still trying to understand and dismantle kind of the legacies of today. And so how we do hear or not hear, see or not see Black women and their pain and their needs, I think is it's relevant. Thank you.
Sure. Okay, Tui, I hate that I'm messing up your name. In the chat, she also said that. Yes, thank you. I apologize. Y'all forgive me, please. That Alaskan Natives and Black people share the same level of maternal mortality in Alaska as well. Yeah. Sure. Are there any more questions or comments? Come on, everyone.
Monique, I see that you've raised your hand. Did you want to go ahead and share?
Sure. It's actually Dr. Monique, and I think it's important. I think as we attempt to dismantle the racism that is inherent in the system that really did grow up, like you said so beautifully on, I'm sorry, the guest presenter, Tabitha, how you said so beautifully that women were taken advantage of, especially Black and Native women. And that legacy of care is still seen today, in part reflected in the numbers. But I think as we discuss this, we need to consider not throwing out the baby with the bathwater. Before we had healthcare, before we had OB-GYNs and neonatologists, 1 in 8 women died in childbirth. 1 in 2 babies died before the age of 2. So we don't want to support the notion that demedicalizing the things that have an impact on improving the numbers is the way to go. I think trying to get the anti-Blackness and the anti-Native is where we should focus, not necessarily in trying to avoid C-sections when heart rates are dropping. Because when heart rates are dropping on babies, we know that that damages the brain, and that matters. So I think both things can be held in the same time, and that's where we might get a better outcome. But I am certainly not the expert in this forum, so.
Yeah, I mean, I think probably the goal would be equity, right? That is my guess. Racism is typically built around subjugation and is really based in inequities. That's how we end up with caste. And so, I mean, I think much of the goal around this is helping us live up to those aspirations of being a just society.
Sure. Ms. McDermott, would you like to, I see you typed it in the chat. If you don't mind, would you like to speak your comment?
Sure. I was just saying that I wasn't trying to say that, like, you know, birth workers are against medical interventions. Like I myself am as a nurse. Like I always present everything as objective information, and just say that it's a choice and it may be an eventuality. And I always present that to my clients. But the equitable sharing of information isn't always the case with every provider or with every nurse or with every kind of interaction. And it needs to be respected that our stories need to be told. And if a doctor is saying that you need to do this now for your safety of your baby without explaining why, the how, the brain, the benefits, risks, and everything else that's associated with it, that's not equitable healthcare.
Thank you.
Hey, I was just going to chime into the conversation and say that I think a lot of what we've discussed tonight really touches on health literacy. And ultimately, I think in order to be able to facilitate that conversation or communication between the healthcare professional and the patient, I think that is an issue that needs to be addressed, and to be able to accurately convey and for that information to be accurately received. So ultimately, the patient and the provider can collaboratively make the best, most well-informed decision as to their care moving.
I see Stephanie has her hand up.
Hi, my name is Stephanie. So I'm a third-year medical student in Tennessee who is hoping to go into OBGYN. So I'm really loving that we're having this conversation and hearing everyone's kind of thoughts and opinions and stuff. I wanted to share some experiences that I have had while going through like my clinical rotations, and also kind of ask for advice from all of you wonderful people that are on this call right now. But you know, while we're talking about maternal mortality, especially when we're talking about Black women in childbirth, there's a lot of anxiety and a lot of fear that I have seen from Black women in my experience as a student going through clinical rotations right now. Most recently, I even had a woman who had a white provider as an OBGYN, And when the white provider was not in the room, told me, the Black student, that she was terrified to have her baby with a white doctor. And that she was even planning to look for a Black doctor somewhere else in a completely different city who she felt would better take care of her and pay attention to her needs and any needs that her baby might have. Not that there was anything wrong with the doctor that she had at the time, not that anything really had happened, or that the doctor wasn't able to share information properly or anything like that, but just this sort of fear that I think a lot of Black women and other minority women have when it comes to interacting with white physicians. I know that there's kind of the saying going around like, police kill Black men and doctors kill Black women. I've been hearing a lot of that going around. I'm not sure if you guys have heard similar quotes to that as well, but I don't, sort of like the advice that I'm kind of wanting is, as I'm going through like my clinical rotations and further in my career, what sort of advice could I give to patients who are having these fears? And I don't know if anyone else on this call has encountered anything similar or would like to share their advice and opinions and thoughts on this.
I saw a hand up. Miss McDermott, did you have something? Well, you put your hand back down. Abigail.
That was a clap.
Okay, good. Abigail, did you have something to say?
Did you mean me? Okay, I don't know if this, yeah.
Is it Abigail? Yes?
Yeah, no.
Sure,
yeah, I'll jump in. I'm a nurse also, and I've worked in the NICU in DC, and I work now as a home visiting nurse here in Alaska at South Central Foundation with a primarily Native population. And it's a great question. And I think how I, not as an expert, tend to approach it is two things. One is for patients, I really advocate to everybody across the board that it's really important to advocate for yourself. It's really important to ask any questions that you have, ask for information, ask if anything doesn't make sense or doesn't seem right. It's just super important to advocate for yourself that way. Partly because, and I'm really clear about this with people, partly because healthcare providers are humans and like are sort of immersed in this world and don't always realize that we're not doing a very good job explaining things. And healthcare workers often are white people who are not doing as good a job as we should be at treating everybody equally or at understanding someone else's experience. And so for both of those reasons, I think it's really important that everyone is encouraged to advocate for themselves and including to be able to ask for a different provider if somebody doesn't feel like a good fit. And again, I just think that's really critical for everybody, no matter what our background is. And then the other half of it is just really speaking up whenever we can to our colleagues about things that we notice, about issues of equity, and pointing out anything that we notice. And I'm not always as good as that as I would like to be, but I think both pieces are really necessary, including that, like, I can't remember your name, but the doctor who mentioned health literacy and communication. Like, I know that communication in the healthcare field is just not what it should be, and that causes problems across the board. And so anything that we can do to improve communication on both sides, I think, is really important. Thank you.
Yeah, I think, Stephanie, my advice to you would be to listen and to listen to understand, and to also really recognize the power differentials. When people are entering the healthcare situation, they're often vulnerable, right? And these concerns are not ahistorical. So that's the other, like, sometimes, I mean, I just think about cases like Serena Williams or, Beyonce, but these cases where people had issues, and even with all their wealth and their power as Black women, these issues didn't feel like they were considered, as if women do have some agency and legitimate knowledge of their own selves. And so I think that even listening to seek to understand can go a long way. And I'm a counseling psychologist, so that's what my PhD is in ed psych, but my training, my program was counseling psychology. And so, you know, my training, it's all about relationships. It's all about listening and all the things you do to help people know you're listening, right? Like paraphrasing. But it would sort of tickle me when in the medical profession, people, as it turns out, the way you talk to people matters, right? The way you say things can tick that blood pressure up or down. So that there are just all of these interpersonal things where I would say, don't forget to be a human, and don't dismiss and don't invalidate. Seek to understand and help them make sense of their, you know, sometimes in just listening to people and creating that space, they can understand their own thinking, their own rationale, their own fears better. And sometimes it helps to calm some of those fears.
Thank you so much for that. As a clinician, I totally agree with what you're saying about just listening and being there and just the approach in which you do it, you know. And I hear people talk about cultural competency. And I don't think there's a such thing as cultural competency, but more humility, where you're just willing to work with the person where they are and experience them where they're at. I have a very good friend of mine who she's Alaska Native and African American, and she just delivered twins. And it was a high-risk pregnancy, and she had to deliver them at Providence and earlier than she wanted to. And she just was very upset about her experience there and said that it was different than at the Native hospital, where people took the time to explain what was happening and just were patient with her. And with her living in Bethel and being from there, that's how she can relate to people. That's what works for her. And I think you have to be able to get with people where they are and take the time to do it. And it's not always ideal for medical professionals or clinicians. You know, people have life, there's things to do. But in order to be effective and to be culturally humble, you have to be that listening person and caring person and take the time. And there's some comments in the chat. Miss Tijuana. Sorry, Miss McDermott.
It's not the city in Mexico, it's Tuigana.
Tuigana. I promise
Yes.
you the next time I say it, I have it. Tuigana. Okay, and so Tuigana said that I have heard many, many stories of BIPOC folks saying that they want more representation within the behavioral health or general health community because they as patients feel that they need to teach their white clinicians before being understood. This exacerbates the burden when seeking care. Are there any programs within healthcare that elevate people of color in Alaska, especially Indigenous, Black, and AAPI people seeking those roles? I don't know if anyone, I am not aware of anything, but is there anyone else?
I think that's a great, place for our team to maybe do some additional digging. I know that resources along these topics are pretty scarce in general, but maybe, something that we can work on and follow up on after the session.
Sure.
My guess too is that would largely be educational institution dependent, right? So we see like the University of Washington having a pretty active PA program in the state of Alaska, and they have a pretty active intentional process for recruiting candidates of color, but not every institution does. And then of course, sometimes they say they do, and that doesn't look like it should look. So I don't know, I'm not aware of anything that the state offers in particular. I think it would come down to what individual educational institutions who are educating those professionals in Alaska, or what does recruitment look like within the facilities and organizations that are recruiting providers, and how are they intentionally focusing on recruiting providers that look like the people that they're serving.
Sure. One more comment that I'll make is Kathleen said people may not know how to express what they are worried about or they need, what they're worried about or they need to know. And so I do agree with that. There's two more. Do I have time to ask those? Stephanie said, thank you for the advice, and she hopes others were able to take away from the question. And I did. I definitely was able to take away some things and have an understanding. Philippa said, I'm working on it. Leanne said the UAA has a RRANN program for nursing. And Tuigana went through that program. Oh, and unfortunately, they basically give books and scrubs. I'm sorry, there's not more positive things I can say about the program.
Hey, LaShonda, if I can. So I think one of the things kind of take home from what I'm hearing in the conversation that segues into the question that Stephanie asked was pretty much, I think really the best way to address this is what we touched on as far as recruiting people, as far as in the healthcare providers that look like the community in which they serve. And I think people who are currently also people of color or minorities working in healthcare, it's being that liaison, being able to bridge the gap, being able to translate the fears, concerns that the patient has with the provider that they're seeing or the care that they're receiving, and being that trusted inside source, if you will, that can translate it in a way that the patient understands, that can abate a lot of their fears, and also voice those concerns to the healthcare team to make them aware of it, and also bring their attention to it in a way that the patient gets care that's culturally sensitive and is also leads to better outcomes for them.
Definitely. Thank you.
Right. All right, thank you, everyone. I just wanted to transition us into our case presentation and offer a few notes about what that looks like. And LaShonda, thank you so much for facilitating those questions as well. All right, so again, we're moving into the case presentation portion of our session. And for those that might be unfamiliar, case presentations are an integral tool that Project ECHO uses to affirm the all teach, all learn philosophy of our program. And the aim for case presentations is to really invite our participants to share their expertise, lived and learned, and to also create a forum where complex issues can be examined with nuance and care. And the great news is that we've already done a lot of that work already. So people should be warmed up and ready to dive further in. Just a reminder that our ECHO cases are de-identified and no protected health information is shared at any time. So just keep an eye out for that when you're participating later in the session and speaking up, especially if you're a provider and sharing your own clinical experiences. All right, so, and after our presenter shares their case, LaShonda and the rest of our team will help ask participants any clarifying questions and gather additional information. After that, we'll go ahead and take any suggestions, recommendations, and comments. And yeah, that's the good stuff. So again, back over to you, Dr. Grier-Reed, for our case presentation. Thank you so much.
All right, thank you, Erin. I am going to begin sharing my screen again. And this case presentation is actually based at the provider level. So it is not based at the individual person level. And let's see, my keys are sticking. This is set in an educational institution. I work in an institution of higher education. And in my first year as an assistant professor, I co-founded the African American Student Network, which was a weekly drop-in group that was co-facilitated by Black faculty, staff, and graduate students, met over the lunch hour with food, so think about culturally responsive, and a friendly space where every meeting began with introductions and check-ins, followed by open discussion. So think about creating community. I describe this sometimes as a therapeutic counter space for Black undergraduates at a predominantly white institution in the Midwest from 2005 to 2020, where counter spaces are those spaces that counter the white racial frame by centering, in this case, the Black experience and Black voices. Certainly, it could be other groups, it could be an Indigenous space, but mine was focused on Black people. I've come to think of AFAM as a social network or institutional or social network level institutional intervention that I co-founded to respond to the needs of Black students where I found social network level outcomes. So for the Black students who participated in the AFAM network, when we surveyed them about who you talk to when you have a problem, they tended to list more people in all. So their networks were just bigger than their non-AFAM Black counterparts on campus. But they were also Blacker. So they listed more people, they listed more Black people, but then they also listed more university connections in their networks. So in short, they just seem to be better connected, which you can imagine creates more opportunity to respond in growth-oriented ways to trauma, especially racial trauma, right? They have more relationships and more social support and social networks to draw on. And so much about AFAM seemed to be about, quite frankly, finding the words for and making meaning of the complex racial phenomena in their lives, naming the unnamed, right? Which is part of what I think Stephanie's question made me think of too, this idea of people trying to process what it means to be Black, a pregnant Black woman who feels vulnerable to her white medical doctors, for instance. Over the years, over 900 students participated in over 400 weekly networking meetings from 2005 to 2020. And this is a little bit, I guess, of sort of shop talk, but these are therapeutic factors that result from group work here, this list. And even though, AFAM was what I would consider kind of a culturally responsive intervention, in some ways it behaved like group therapy groups, quite frankly. So catharsis, which was one of the first themes I identified through qualitative interviews in AFAM, was connected to safety. Like, people want to feel safe. And safety's been identified as a prerequisite for catharsis. So in some ways, as I think about Stephanie's question, I'm continue to think about that. Apparently the woman felt safe enough to talk to you, right? To say things that they wouldn't say otherwise. And so how do you create that space where people feel safe, where they can let go? In AFAM, people talked about being able to spill their guts, being able to express themselves. And all of that cathartic process of being able to let go and listen to others was rooted in a safe space where they also felt connected, like they knew that they were not alone. And that's the idea of universality, to know you're not alone, struggling in isolation, that you're part of a community. And there's a common ground and a common experience. And then there's existential factors, which, and for my case, it was students who were just such extreme minorities, right? It was like, maybe you go your whole day only seeing one or two other Black students in your class. And so just the idea of Black people existing in this space was quite literally an existential issue. And students said, oh, when you created this group, it was like somebody cares about us and this little bit of Black people that exist on this campus, and they're helping to do the work to affirm our existence and that we belong here. And that was validating. And you can imagine that sort of facilitating some of that racialized labor around affirmation, which provided corrective experiences where, the campus could be rejecting and unwelcoming, but where people found a space to belong, a space that was safe, a space that affirmed their existence. That was a corrective experience to the invalidation and the negative experiences encountered elsewhere. I mean, and that is another way to think of it. How can you provide corrective experiences in terms of some of the, not just the physical health part of it, but right, the psychological pieces, because people come in often wounded in many ways. And so in AFAM, it was through validation and intellectual stimulation and connection and community that people had corrective experiences. And they talked about it helping them get through the week, a sort of fortification or experiencing resilience in that space. There were other things like helping others was important. Empowerment, this makes me think of the cohort group that you were just talking about. Where the imitative behavior, there was power in being able to see models, being able to see other people who looked like them, showing leadership, striving to succeed. All of those seem to be an important part of the network, and also help to instill hope, help people pass along and share information, be resources to and for each other, learn from each other, develop new socializing techniques, being the change, right? Figuring out how to create spaces even outside of the network on campus, in the dorms, celebrating Black History Month, that kind of stuff. And finally, just having a home base on campus where their lived experiences were valued, accepted, and respected. And after the first 10 years, I sort of looked at the topics that came up for students, and the navigating college life, understanding racism, exploring identity, standing up for justice, finding love. A lot of these are really, these are emerging adults, and a lot of this looks just like kind of the normal psychosocial task of emerging adults, except for, understanding racism and standing up for justice. These didn't make their way into the original conceptions of emerging adulthood so much as identity, finding love, and finding your career path. But as we've come to look and understand diverse people of color, it turns out that understanding and being able to make sense of racism, which is also maybe part of that, right? People asking about, I don't feel safe here, trying to understand like, why is it? And maybe it's the legacy of racism and how that's impacting me, this huge history in this moment in time, in this space. So understanding how and navigating racism in their own lives, and then how to stand up against it. But honestly, even finding love was racialized, right? People, what does it mean to be in an interracial relationship? Can I go outside of my race, and does that, and still affirm Blackness? If my life partner is also not Black, kind of thing. Or what does it mean to navigate this institution or college life as really an extreme minority, and the lack of racial diversity, and the isolation, and the feeling pulled, right? Because my educational institution is based in a white racial frame, and I'm Black, and I'm trying to live authentically Black. How is this education going to change me in ways that maybe I don't want to be changed? So race seemed to play a role in all of these, even the ones that seemed kind of more prototypical. And as a facilitator of the group, for me, some of the key skills were really about linking. That means being able to link students' stories to each other, but also to the collective struggle, really helping them understand their struggles in this moment and in this time and in this space, and how it was connected to something larger, to a larger collective struggle and narrative. Being able to share of myself in authentic ways, and often being able to contain. And that wasn't always easy, but containing difficult emotions such as anger or pain in the room. So not dismissing, not shutting it down because I'm uncomfortable, but being able to create a safe space for those kinds of full expressions of the human experience. So, sorry, my keys are a little sticky. My question for you as I end, and I am gonna push you to think about your own institutional challenges. For me, recognizing and relying on informal networks was kind of an Indigenous form of coping for Black people. That was just what they did, more so than some of the things I was trained to do, like just therapy in a counseling center. And that creature comforts like food and things like that work to create warm, friendly, family-like environments in the African American Student Network. I co-founded this social network to intervene against anti-Blackness and the white racial frame at my institution in a way that facilitated cultural health for Black students. And so my question for you as we come back is, how can you transform your institutions in ways that facilitate cultural health via practice, policy, or even new ways of thinking? Thank you.
Thank you, Dr. Grier-Reed. I can kind of summarize, but I think that you all heard nice and clearly. I really would like to open it up for clarifying questions and further discussion. I don't know if I need to repeat the question, but if there's any questions, I can do that. But are there any comments or clarifications that are needed? Ms. Kathleen Easley, you have your hand up.
Yeah, I was just going to say, kind of tying to what she finished up with is, you know, I'm a school nurse, and, you know, Anchorage has a really diverse population. And so we, the last few years, have started doing a multicultural night and having families bring dishes to celebrate and share their culture. And I feel like that's been super rewarding, because oftentimes people don't even know what other cultures are, you know, so it was eye-opening to some families, and in a warm, welcoming way, right? Because we're bringing it with food, right? Food's always the answer. That was just my 2 cents. I think in education, a lot of us do that and try to, you know, build relationships that way.
Thank you, Kathleen. As a teacher for 6 years, I totally agree. Before I was a social worker, I was a teacher, and food is the key to people's hearts.
Yeah, that's the one article I was reviewing about the cultural center talked about food, and for the longest time I could never explain it, but there is something about, you know, creating space and place, and if people have been institutionally unwelcomed and marginalized, you know, there's always something about food that brings you in and makes you think about and feel like family. And you know, I always love a good multicultural potluck. It takes me back to the 90s, right? The heyday of the multiculti movement. But, you know, as I think more, some of these questions, especially that Tuigana has brought up and really pushing the conversation, are about how do we respond institutionally? You know, how do we respond institutionally and wrestle with these legacies where, you know, it is complex, that there are histories in which people have felt disenfranchised and marginalized and distrusting. And then there are experiences where people might still continue to feel either unempowered or dismissed. And yet, and now I can't remember her name, but as the other good doctor raised in the beginning, like, you know, there is sometimes just good, sound, efficacious medical treatment that we know needs to happen, but we cannot dismiss our histories that create for people very real suspicions. And how do we, or you as an institute, I mean, I think about this a lot in education, less, but some in healthcare. It's interesting in APEM, a lot of the students would talk about going into healthcare because they wanted to change it, because they felt like their doctors didn't know anything about their cultures and didn't care. And maybe, and you know, these were not like white women, right? These were Black women, and a lot of times Black immigrant women who felt particularly kind of dismissed and invisible.
Hey.
Go ahead, Obi.
Oh, I'm sorry. Yeah, so Dr. Grier-Reed, I just wanted to kind of segue and maybe ask you a little bit as far as just the impact that COVID has had on community, especially in minority communities. Kind of during the time of isolation and social distancing, and community being the bedrock for how a lot of the people of color and minority communities have been able to be resilient and kind of navigate some of these spaces and issues that we're discussing tonight.
You know, I think COVID has ravaged, especially BIPOC communities. You know, COVID, as people like to say, laid bare the disparities. So, you know, difficulty initially getting access to vaccines. Once they became available, then it was like, well, I don't want them. But when they were hard to get, you know, that there was questions around that, of course, around the mortality rates. And I think for everybody, though, COVID has been a collective trauma for everyone. And to have COVID and right in the middle of that, George Floyd, and on top of that, all of the hate crimes and violence against Asian Americans. And I mean, they're just, I think COVID has just sort of multi-layered the trauma that people have been experiencing and created isolation, which is not good for any of us. Like, we as humans are not meant to be isolated. We are sort of meant to live in community. And so COVID has created challenges in that way.
Yeah, to that, that's a great response to that point. Do you think that because COVID in a way has, I think maybe we have a shared, I guess, reality, and as a result of it, and maybe bringing the humanity out of people, since this is a trauma that we're all experiencing collectively, do you think there are opportunities past COVID for post-COVID to maybe bring about some bridging some of these divides and bringing us to hopefully a better place than we were before?
I appreciate that sentiment. I don't know that that's been the reality. You know, we're living in a really tumultuous, transitional time in this new century where there are many things happening, not just the pandemic, obviously, but we're also in a period of racial backlash, quite frankly. And then we're also in a period where young people are really existentially worried about their futures with climate change. And then there's at least, I feel like, a dozen other things, like the way that social media and technology has sort of changed the way we relate to each other. And unfortunately, none of those things at the moment tends to be cohering us all as a society with one shared mission and one shared vision of reality and of our country. And in fact, you know, one of the things that became so disturbing is this whole idea of misinformation, and that people could, you know, we get a little tribal. And so we just talk to the same old people, and we harden in our beliefs about the same things that are very different from the reality that this group over there is facing. So I mean, I can appreciate, you know, the idea that maybe it leveled, COVID sort of leveled us all, except for that it didn't really impact everybody exactly the same way. It didn't really impact communities exactly the same way. The last I heard, there were still about 600 people a day dying from COVID. That could be different because the numbers change all the time. But we're not talking about it as much. And so is it because these are people that are perhaps less resourced and slightly more dispensable that we're not as concerned? So I think COVID laid bare some difficult realities, and there are still the challenges that we as a society have to grapple with. And I think I think we're all human. So in that way, we all have a shared experience. But how we grapple with the myth of progress, I think will be important for our shared future. And we tend, you know, the thing I love about America is the optimism and the hope, you know. But I think the downside of that is sometimes that optimism is based on a real sort of ahistorical understanding of ourselves in ways that leave us unmoored when trying to understand the present moment that we find ourselves in. How did this happen? We just had a Black president, and yet we are a country where people have been in bondage or living in some sort of racial caste system for much longer than they've been free. And in fact, I think, oh gosh, I was just reading, I wish it was better at numbers, but I think that there is no African-American person, and we'll just stick with African-Americans, like I'm not even talking about Indigenous people, or Tabitha has brought, like people have raised that, you know, so we'll just stick with the one that I spend a lot of time studying, will be alive for the length of time that this country has been free, for as long as people were enslaved. And that will be in something like the year 2111 or something like that. So we're at a place where we have a historical reckoning, and there's like some truth telling that has to happen to help us better understand and come to terms with how we want to live as a more just society. And so in transforming ourselves, we do have to go beyond the individual to begin to think really seriously and deeply about the collective. And what does cultural health look like for us as a collective?
So Dr. Grier-Reed, would you say that, to me, that sounds like a recommendation, being able to make it more collective, us do the work and then also do it outside of ourselves. And Panna, she made a comment on here, and it sounds like what she's doing, having been a nurse for 30 years or being in the district for 30 years, it sounds like something that maybe she's doing to make a difference. Panna, would you like to speak to that?
Yeah, when I came into the Anchorage School District, I was the third African-American nurse since Anchorage School District's inception. And I had to not only represent myself and my race and my profession, but working with young people, empowering BIPOC students to speak truth to power and to strive for excellence while supporting their journey. And it is an ongoing, beautiful, but painful process. But it's what I do every day at Service High School. And I'll keep doing it. But yes, it is good work.
Thank you, Panna. Kathleen, you had your hand up?
I was just clapping for my school nurse friend.
Okay, I'm sorry. I see the claps and that. If you want to speak, please go ahead. I'm about to call on some people in here. Barbara, Stacy, I don't want to be rude, but is there anyone who has any other comments, any insight? Bianca, Ben?
I wanted to add to it too, that I wish that we, had, I'm a part of the Alaska Coalition of BIPOC Educators, and I feel like one of the needs we have in our system is having, Black and BIPOC educators, because I look at the diversity of our community and it is not represented in the school district, in Anchorage for sure. But I'm sure that carries over through the whole country. And I wonder if there's insight or, ways to, have, I mean, not necessarily even legislation, but like funding to push through to help, get folks into education or into these key, nursing programs. Like that program they were talking about is the RAN program, which is supposed to help Alaska Native people go through nursing school. But then she said the program itself is not doing really anything more than providing books and scrubs. So, it's wanting these things, but then making sure that they're actually doing what they're supposed to be doing, right?
And then there's also like, in terms of RAN, they like advocate to the university that basically like they need to lower some standards for rural students just because rural students want to still be nurses. And the strict requirements are a barrier to a lot of students. And so just having like a nuance within the system would be very helpful for not only Native students, but other, people of color.
Thank you.
Yeah, I mean, I would say that's right. Like, first of all, acknowledging and understanding the history. Why is it that there are very few Black, Indigenous, BIPOC educators, right? And then thinking about the policies, because the policies didn't come out of nowhere. There is a long history around the policies, and thinking about how these policies are working or not working in terms of equity. And so I think those are ways to begin thinking more organizationally, more institutionally, and less individually about how we go about the work of equity. In my college, my dean, his signature initiatives are around partnering with our tribal colleges, both at the undergraduate level, but then also at the graduate level, and creating cohorts of Indigenous students who are coming in. And then, you know what that means? We also have to start thinking about how we do pedagogy, right? Right. We have some Indigenous professors in our college, and we have to think about, well, really, how is our institution set up? Because I'll tell you, it really probably was never designed for Indigenous students and faculty. I mean, I am at a land grant institution, and people today, you know, everybody has their note about how they're doing their land acknowledgements, but some people will call it land grab. And so how do we reorient towards equity? Because you can't just invite a few people in and keep doing things the way you've always done them and expect for everything to change.
Absolutely. That's good.
I just wanted to add one little thing to that is in having more BIPOC healthcare providers and faculty to educate the healthcare providers, I think locally, the University of Alaska system needs to put a little more effort into recruiting BIPOC postgraduate students to become educators. I had to seek my post-education, my doctorate at Purdue because UAA and UAF were not open to including public health PhD work for me. They didn't recruit me. And so and I'm an alumni and a 47-year Alaskan resident. So I think that for us to see more educators that are BIPOC, we need to have local institutions educating more educators that are BIPOC.
It is a long game.
Mm-hmm. It's systemic, hitting it hard on a larger scale policies and things. And it's exhausting, but it definitely makes a difference. So those are great recommendations.
I just
Maddie,
wanted to add the chorus of voices saying that, yes, we need BIPOC representation in our education systems and in the healthcare provider arena. And I mean, it's hard. It's a lot of work to just go through that. And then you add on top of that all the other layers of your racial background, you're the first person in your family to do this, or, you're not part of the straight white community. There's all of that. It's a lot of work. And just like Dr. Grier was saying, it's easier to avoid those situations a lot, right? And what happens when you avoid is you get the worst health outcomes. And
Maddie, I will say this. I feel mixed on that. Like there are some studies that have said that. On the other hand, there is this part of me too that is like, do we ever have the opportunity to take a break? Right.
Yeah. And I really feel you on that one.
Yeah, and so, my self-compassion message is it is normative. And it is also okay to think about how self-protection shows up in your life. And if sometimes that feels like needing to avoid that meeting or that person or that discussion today, you take that.
Right. Yeah. So selective avoidance, I'm all for. But one of the protective factors that really stuck with me and in your presentation was the cohesion part. When I was an undergrad, what really helped me was finding the LGBT Resource Center and finding my people and encouraging each other. And, I read Dr. Vivek Murthy's book on Together, and just finding your people and connecting and maintaining those connections through like pandemics really does make a difference. And I think if we get BIPOC groups, like at SCF, at South Central Foundation, there are learning circles. And these are circles or support groups where people with, similar experiences can get together and just be together.
And be, that's right, just breathe.
Mm-hmm. Absolutely. Makes such a difference knowing that you're not the only one, you're not isolated. So thank you.
Absolutely.
Thank you. Over here in the chat, I'm not going to go through everything, but there's a huge amen corner. I'm exhausted. Oh my God, I'm tired. And it really is true. This has been so good. I appreciate it. Yeah, if I start talking, I feel like we might be here for another 30 minutes, so I won't. Erin, would you like to continue on?
Yeah, we are at time. I see, Obi, you'd raise your hand. Do you have a brief, comment before we close? And LaShonda, of course, I want to offer that to you too, as well. I know that if you have a comment, feel free to share it. We can be a little flexible. We can skirt around some of the rules and add a few extra minutes.
Hey, thanks so much, Erin. I'm not going to belabor the point. I honestly just want to express my gratitude to our presenter as well as everyone else on the call tonight. Just everyone's engagement, their involvement, everyone's openness to hear other people's realities and experiences, and how we bring that to the table to hopefully be able to collaboratively understand ways that we can work together in whatever capacities in our day-to-day and professional lives to bridge gaps and hopefully, create progress. So thank you to everyone.
And I'll just say, I really appreciate Dr. Grier-Reed, just you creating that program there at the university. It's super important. It reminds me somewhat of the programs that are in place at the universities for first generation college students. And a lot of the times you see Black people and, BIPOC, that's who you see there. And so those programs are very important and appreciated. And so my takeaway is that's a recommendation. Like, what would I do? I would want to start something like that, even as a clinician at my agency, just being able to have a place where people of color feel like I can come here and I can really speak my mind. I can speak about racial trauma. I can speak about these things in a safe place and be heard. And so you're a great example of that by what you established. And so thank you.
Thank you so much. Thank you all for your attention and your thoughts and your community. Thanks for inviting me in.
All right. I also say thank you again to our participants as well for being here and really helping to drive this discussion. A few announcements. Unfortunately, we're a little past time, so I'm going to wrap up pretty quickly here, but please check the chat box for the link to the evaluation, where you can provide us with valuable feedback and also claim your CME and nursing credits, first by filling out that evaluation form and then being redirected to where you'll be able to download your certificates of completion. Also shared in our chat box is a link to the box folder where you can find session recordings, presentations, and other resources like slides, links shared in the chat, etc. And these will typically be posted within 24 to 48 hours after our session. And please note that some of that information might be removed due to its sensitive nature. Once again, if you have any questions, comments, or a case you'd like to present in the future, please fill out the jot form also linked in the chat. Our next session is Thursday, May 10th, and we'll be discussing healthcare access experiences of Black, Indigenous, and people of color with a didactic presentation by Dorothy Roberts, award-winning author and expert on the interplay of gender, race, and class and legal issues concerning reproduction, bioethics, and child welfare. And I know we actually touched a little bit on bioethics and child welfare today. So I look forward to continuing those conversations during our next session. And we hope to certainly see you there and engaging around that material as well. Again, thank you to everyone for your participation today and for your contributions in building this forum for discussion and learning. We look forward to seeing you next time. And until then, please do your best to take care of yourselves and, as always, each other. Have a wonderful evening, folks. Hub team, if you wouldn't mind hanging on, we'll go ahead and have a quick debrief. Thanks.